Okay, fantastic, it's recording. Okay, over to you then, Lewis.
Well, thank you very much. I'm going to start in what has become the traditional way by sharing my screen.
Okay. Just to say, actually, if you've got questions, please put them in the chat. We'll take questions at the end, but if things occur to you going along, put them in the chat, or we'll pick it up at the end as well.
So I'm hoping everyone can see that. My title slide. Thank you very much for inviting me, and to everyone who's come. I hope you're well and getting through all of this. When we talk about suicide prevention in the COVID era, we're talking about a combination of things. We're talking, of course, about the impact of COVID on our emotional lives. But we are also talking about what was happening in suicide prevention before COVID arrived. Suicide prevention as a challenge to us didn't start with COVID. There were already some quite serious suicide prevention priorities that needed to be addressed. And then, of course, there is the next phase. It is an evolving pandemic, and how it has affected us until now is a guide, but not an absolute guide to how it may go from here. So suicide prevention in the COVID era is a mixture of how things have been recently, but also the past and where we're heading. I want to talk about some of these issues as far as we have data. I want to draw on the findings of the National Confidential Inquiry, large research project here in the University of Manchester. But also I want to draw on the findings of many of our partners in research, academic partners, statistical agencies, and others that we have worked with over the last year and a half or 2 years. Quite a lot of slides to show. So you need to engage your personal line graph appreciation software. You need to have in mind something that we always say about our figures. You'll see a lot of graphs with numbers going up and down, trends and rates and so on. But behind these statistics, there are real people, real lives lost, often lost though prevention was possible, and real families devastated. And we never forget that in our work because we work closely with families, and we always mention it when we're talking about our data. So what was happening to suicide before the pandemic started, the background to where we went from there? Well, this is the suicide rate in England up to 2019. And so look at the middle line there. It shows the general population rate for the previous 20 years or so. And you can see that around about 2006-07, we had the lowest suicide rate ever in England. So that was the lowest figure for about 150 years. And then in the next few years, we saw a recession, an economic downturn that put the suicide rate up here and in many other countries. And at its peak, the suicide rate, the number of suicides, I should say, increased by about 700 deaths a year. So it's a pretty substantial effect and very important to where we're going now. And then the suicide rate started to come down. Let me just see if I can get a pointer. So there's so many options. So there's a pointer. So the suicide rate started to come down. And then in the last couple of years, pre-pandemic, the rate began to go up again. And that may be partly explained, though only partly, by a change in the legal definition of suicide towards a lower threshold at inquest. But it's very important to know the suicide rate was rising just pre-pandemic. So about 10 people per 100,000 per year. That's about 5,000 deaths per year in England alone. Here's also how it looked pre-pandemic. This is now an age sex breakdown. So the blue bars are men, the orange bars are women by age groups. You'll see, first of all, suicide rates generally much higher in men, roughly 3 times as high in this country. It's an almost universal finding, higher rates in men, except in rural China. But higher rates in men, and not uniform. Throughout the age range, the highest rates are here, men in their 40s and early 50s. That's probably driven by economic factors, by alcohol to some extent. So some very important drivers of national suicide rates, and probably quite well known now. Middle-aged men, highest rate on record. About a third of all suicides in England are in this relatively narrow demographic group. But more recently, perhaps less well known, is the higher figure in older men. So men over the age of 85, fewer of them, but the rate is another relatively unrecognized peak. A group that we often hear about, always an important source of concern for those of us in suicide prevention, is the youngest group, people under 20. But as you'll see from the graph, they actually have the lowest suicide rate of any demographic group. So it's not always about the rates, it is also about society's view of the people who might be affected. Well, they have the lowest rates, but here's what's been happening to young people's suicide in the last 20 years. So again, look at the middle line, that's the general population, males and females combined. Again, a relatively low point reached slightly later, around about 2010. And then since then, numbers are smaller, so a degree of volatility in the figures, but overall a relatively persistent rise in teenage suicide rates to what are now historically high figures, particularly in girls. Why has that happened? Well, it hasn't just happened in this country. It happened in some other high-income countries too, and they tend to be united by one feature, which is income inequality. Now, that's often not a direct cause, but it may be a marker for something that's happening in broader society that's putting young people at risk. So the pandemic came in 2020, and straight away, people were concerned about what its effect might be on mental health and what its effect might be on suicide rates specifically. So it wasn't difficult to see why that concern had arisen. People might be anxious about the illness itself. Some people would be more isolated. They might lose support. There may be disruption to the kind of care that they had come to rely on. There were specific risks associated with alcohol, domestic violence, bereavement, of course. And underlying all of that was the potential for the economy to be affected and for suicide to be affected as a secondary consequence. So plenty of reasons to be concerned. And this is a paper that a group of us academics worldwide put together in the early pandemic to comment on what the risks might be. And the point we made in this paper was that we knew quite a lot about suicide prevention from national strategies around the world, and it would be possible to apply that knowledge in this new, and as people always used to say then, unprecedented situation. That meant that some measures of a public health nature directed at the population as a whole on some of the factors I've mentioned, economic factors, isolation, and so on, and some targeted interventions at people who might be most at risk, including people who had pre-existing mental ill health. So our message in this paper, this is published early in the pandemic, was that we shouldn't regard a rise in suicide as inevitable because we know quite a lot about what we might do to protect the population. Nevertheless, the story got around over the next few months that suicide rates had escalated, and there was no shortage of claims in the media about and predictions about where suicide rates might go. People were feeling more stressed, and so they extrapolated to a likely impact on suicide rates. And this slide is just a montage of one or two of the numerous claims and predictions that appeared in the media and also in the academic journals. The most notorious was the one at the top, a tweet that appeared that said that suicide had gone up by 200%, which is an interesting figure in itself. It means a tripling of the suicide rate. That would be truly unprecedented. So a 200% rise in suicide, for which there was no evidence. This is quite early in the pandemic. And that tweet was reposted 31,000 times that day. So the story got around that suicide rates were rising. And here's some of the other media reports, but just to make the point that it wasn't just in the media. There were people who, out of genuine concern, were expressing the fear that suicide rates would escalate. So what did we actually find? Well, I want to draw now on an academic group at UCL and a study they've been doing. We've been working with them on some of their data, but this is these are their figures. Right from the beginning of the pandemic, they began to conduct a large national survey, around 70,000 people in this survey, generally balanced as reasonably representative of the population, but no pre-pandemic data. So it was about how things were changing during the pandemic. And they were asking people about their well-being and about their behavior during the pandemic. And they had a good level of continuity because people were recycled into this survey. So you took part every few days. And for that reason, changes, it's a good survey for looking for change. And there's a lot of data in this survey. It's a really good study, actually. This is a slide I've just selected because it's showing what they refer to as COVID stress. This is the number of people who said they were stressed by COVID. And as you can imagine, right at the beginning of the pandemic, that's here. Most people said that. And then the dotted lines are referring to various milestones in the pandemic, changing in lockdown. This is the first lockdown. Here is second lockdown, and so on. And you can see that initially people felt very stressed, and then that seemed to subside. And then again, more people then during second lockdown again recorded that they were stressed, and then back to a lower figure falling during 2021 towards the end of last year when the figures began to rise with the appearance of the Delta wave, but not to the level that they were at before. But no doubt people were reporting stress in relation to the waves of infection and the restrictions that came with that. And just to make a point in passing, that the pattern is quite similar according to who you look at. And that's also true of people with mental health problems in this bottom right graph, but all the way through, there is a difference between those with mental health problems and those without. So even though the pattern was the same between those two groups, there was a consistent difference in how much stress those with previous mental health diagnosis were reporting. Now, another important survey was conducted by the Office for National Statistics, another very valuable partner. And they did have pre-pandemic data. So they were able to refer to how much anxiety and low mood had changed pre to post pandemic. And they looked at the factors that might be contributing to any change. And so they found that people became more anxious during the COVID era. And so if you look at this vertical line here, this is the line that you should refer to in relation to why people felt more anxious. So each of these in this left-hand column are various factors that might have influenced people's emotional state. And then to the right of this line, it's showing how big the impact was of each of those factors compared to this baseline. So you can see that several things, people generally were more anxious and several factors were contributing to that. One of them was being female. Another one down here was being in a marital relationship or equivalent. Down here, disability, more anxious. But by far the most powerful factor, and the one that came out in the regression analysis, was this one here, and that's people feeling lonely. So people who felt lonely, that was the biggest driver of population anxiety. So there's another vulnerability that we need to be conscious of. Mental health diagnosis previously, now people who felt lonely. And an important connection, because those people who had mental health problems also reported they were more likely to feel isolated or lonely. So they're just the beginning of a cluster of risk. But that's how people felt. What about suicidal behavior? So this slide now is showing self-harm, and this is we monitor self-harm through different centres in the country, and this is data coming through Manchester from emergency departments, and it's showing what was happening throughout the first year of the pandemic. So this is self-harm rates. If you look at the, it's actually numbers, in fact, the number of presentations in hospital. The yellow line is the total number, and here's the first lockdown. And contrary to people's expectations, self-harm fell during the first lockdown. I suppose people were told to protect the NHS, so that might have been one reason people were staying away. But once lockdown was reached, was ended, the figures slowly began to rise, but only slowly, and it took a long time for them to return back to pre-pandemic levels. So it probably wasn't just an effect of people staying at home. Then we got into the second lockdown, and this time it was different. There was no fall. Now there wasn't a rise, but it did suggest that something about second lockdown was different. So no protective effect. That's not to say that the pandemic was not influencing self-harm behavior. So this is an interesting study from colleagues of ours in Oxford who looked at the reasons people attended emergency departments as a result of self-harm. They assessed causes, multiple causal factors, and found that almost half of people, particularly in women, said that some COVID-related factor had influenced their self-harm. And that was particularly feeling isolated, there's poor mental health, of course, isolated, disruptions to routine, and fear. So those same factors coming through to shape the pattern of self-harm, even if the rates weren't rising. Now you're bound to say, well, most self-harm doesn't get as far as hospital. What was happening to self-harm in the community? So back now to the UCL survey, which asks people that question. And here's a slide summarizing their data. So each of these slides throughout the first year of the pandemic, throughout the second year, no sign of any rise in self-harm in any group. Some volatility maybe in the figures there, but no overall rise. And this slide, this top left, is showing what you'd expect, which is slightly higher rates in young people. Bear in mind, the definition of young people changes from one study to another. Here it's people under 30. But down here again, bottom right, again, people with mental ill health, higher rates of recent self-harm. What about suicide itself? Well, normally we rely on the Office for National Statistics for suicide rates. They collect information on suicides confirmed legally at inquest, but inquests don't happen quickly. There's a gap between death and inquest of, on average, around 172 days. So it takes 5 or 6 months before those figures might begin to come through in any reliable way. And so coroner's inquests were not a useful source of information in the first year of the pandemic. And in any case, the inquest system was itself disrupted by COVID. So we set out to collect what are referred to as real-time data from some parts of the country where they seem to have the figures. So this is now real-time data, real-time surveillance, RTS, as it's called. It was already established in some parts of the country to monitor local patterns of suicide. Areas collect those figures pre-inquest. As soon as a death occurs, it's recorded. Of course, it's a suspected suicide at that time rather than confirmed. But we put together the data from those parts of the country that seemed to have reliable data. So we collated local data into a national level data collection. It wasn't the whole country, but at national level. And it consisted of 10 STPs. So that was then the current NHS region. So these are parts of the country marked there on the map in the dark areas. So 10 parts of the country, total population, 13 million people. That's a quarter of the country. And we had those figures at the end of the first year of the pandemic. We had the figures for up as far as October from January 2020. There's the paper that we published. What did we find? Well, we had to make a comparison between pre and post pandemic months, because most of these RTS systems were relatively new. They didn't go very far back in any reliable way. So the question was, were the months after the pandemic started showing higher suicide rates than the months before? And so here's what we found. This is summarizing the result. Some change, some slight slightly high figures here, but overall, no change pre to post pandemic. And these are the actual rates that, the numbers are that we found per these are monthly figures. And in anything that was slightly lower in the post-pandemic period, particularly towards the later part of the year, we found no significant rise in any individual month or in any period. Here's the lockdown period, no rise. We had a limited comparison with previous years, again, no difference. So what did we conclude? Well, we were pretty cautious about the conclusions, I should stress. So we, the Confidential Inquiry, published these figures. We said that the large rise that many people had feared had not happened. And in fact, we hadn't found evidence of any rise. But a number of caveats were applicable. First of all, these are early figures. Secondly, they're overall figures for the population. They may mask a degree of variation between population subgroups. They may mask a degree of variation from one part of the country to another. And in any case, this is a relatively new way of measuring suicide, and we have to be careful about the conclusions. We were still concerned that if the economy took a nosedive, then that would affect the figures. But we were supported in what we produced by the international data. So by now we were beginning to see figures from around the world, from Australia, New Zealand, some parts of the US, Canada, Scandinavian countries, and some other places, and a reasonably consistent message summarized in this paper here with Confidential Inquiry authors in it, large study led by colleagues in Melbourne and in Swansea. And here, the main result on this slide here, so it looks a complicated figure, but it's not. So again, the vertical line is showing what you'd expect as a suicide rate, and the horizontal lines are showing what was actually found in each of these parts of the world. And where these horizontal line crosses the vertical line, that means it's in line with expectations. No change, no overall change, at least no statistically significant change. And almost all parts of the world that had figures had horizontal lines that fell on the vertical line. So no change in most places, although there were a couple of parts of the world which reported low suicide rates. So several places said that the suicide rate had fallen. So reasonable international consensus growing that the first year of the pandemic was not producing any impact on suicide rates, despite the concern about distress. Most of the figures came from developed countries, rich countries. So we were a little bit lacking in developing countries, low income, middle income countries. The effect may be different there. And of course, there is again this point that some places may have seen, may be masking variation. And this is just to make that point about the figures that we were seeing from one part of the US, which is Maryland, also seen in some other states as well. And it's showing what we were finding overall, which is that as the pandemic started, the suicide rate in most people in that part of the US was actually falling, but that there was a difference based on ethnicity. So it fell in the white population, it didn't fall, and in fact appears to have risen in the Black population in those early days. So it's just a reminder that there may be variation underneath these headline figures. An ethnic variation hasn't been found in many places. It's quite difficult to look for that. And the authors assumed that this again was some kind of economic marker. So people who were poorer were suffering more, their mental health was suffering more. Okay, back to this country now. So this is by September last year, September 21, we finally had figures from the Office for National Statistics, and here's what they showed. They, this time, unlike our RTS figures, they were able to comment on the whole population, this is England and Wales together, and they were able to compare to previous years. They were, however, still looking at the relatively early period of the pandemic. What did they find? So here is year-on-year suicide rate in England and Wales, and they found a small fall in 2020, sorry. They didn't make too much of the fall. They said that they preferred to say there was no rise, but there was actually about a 5% fall, and that was mainly in men. So some suggestion of a sex difference there. And when they looked at different age groups, they found that it was predominantly in young people where the drop was about 30%. So we're very worried about young people, but in fact, in the early pandemic, it looks as if their suicide rate fell rather than rose. There was one exception. There was a small rise in older women over the age of 75. Now, the numbers are relatively small, but they looked as if they were the group whose rates had gone up. And this mattered because you could see why that might be possible: illness, bereavement, isolation. But it was also found in the SARS epidemic in Hong Kong in 2003. The group who were most at risk were older people, especially women. Now, you might say, well, all of that's still 2020. What's been happening since then? Our figures are still the only figures that take us into the later part of the pandemic. So now, this is the previous slide from our RTS data extrapolated into the early part of 2021 up to April. And you can see then, so there's the graph I showed you earlier, into this second lockdown and out of it again, still showing the same pattern. And now, although figures aren't quite ready to be presented publicly, we now have figures taking us right up into the later part of 2021, where the same pattern is found. So still, as far as we can tell, the general population rates have not risen. Now, what reasons can we give? Is this counterintuitive? Why, given all the concerns about mental health, might we be seeing no rise? The first thing to say is that it doesn't necessarily follow that more distress means more suicide. I don't think anyone is disputing that the population has felt stressed, that rates of mental ill health have risen. But the question is why that has not translated into suicide rates. And it may be that alongside more risks, there have also been more protections. And we need to understand the nature of these protections because they may be important as we move into a further period in the pandemic. So levels of distress and mental disorder don't always predict suicide. Bear in mind that depression is much more common in women, suicide is much more common in men. So there is one of the most familiar examples of why these two things don't always match. But what else could it have been? Well, it may be that we were seeing during the pandemic, particularly in the early period, greater vigilance and support from families and friends and neighbours. So counteracting some of the effects of the fear and the restrictions. It may be that there was a broader social cohesion effect, something more abstract, society pulling together to get through, especially if the crisis might be short term. So if we can just get through the next few months together, support each other through this terrible ordeal, then maybe we'll be okay. Maybe that kind of thought held people together. The government deserves some credit. The government introduced some very important economic protections. Now, they were mainly done for economic reasons, but their secondary benefit on mental health is likely to have been quite substantial. So this was in the furlough scheme for people's jobs and supporting people who were on universal credit. And it may be that the restrictions also prevented access to some important methods of suicide. So a number of possible reasons why this might have happened. This is just our paper that we published about suicide rate not going up. And if that's so, then how much of this can we continue to rely on? The economic stresses, if anything, look more serious going into the current year. There are concerns about people's energy bills, concerns about the cost of living. The protections, broadly speaking, haven't been maintained. So it could be that that benefit isn't something that we can rely on in the future. And the people who might be most affected might be men. This is the graph I showed you earlier about the rise in suicide rate during the recession. So two things to note. One is that the effect was greater in men. And the second thing is that it was long-term. So it didn't just happen in 2008 when the recession itself hit. It was the actual peak of the recession effect was around about 2013. So 5 years later. So any protection needs to be long-term to be effective. We have new stresses for the population, long COVID. We know that long-term physical disability adds to suicide risk. And here is a new potential source of long-term physical disability. Many people are seeing a future in which the restrictions have been lifted, but for those for whom that's difficult, it may exacerbate their isolation. So while the population as a whole becomes less restricted, that may leave the more isolated people, older people, physically ill people, disabled people, might leave them at a greater disadvantage than they were before. And that disadvantage could be dangerous. There are undoubted pressures on public services, particularly the NHS, and that could put people at risk in the next phase. And then there is this sense that the pandemic is continuing, a further wave, very powerful at the moment because of the Omicron variant. And this sense of that we're never getting back to normal, an emotional exhaustion that could come across the population facing further waves of infection. So there are reasons that the suicide rate may have stayed down during the first year or so of the pandemic, but we can't rely on those reasons in the future. Who should we be most concerned about? Well, let me mention a couple of studies that we've carried out in a confidential inquiry. And here I want to refer to the inquiry team, but particularly Catherine Rodway, who's led two of these studies that I'm going to mention. So men and middle-aged men in particular, I've mentioned the concern about economic factors. We've done a national study in which we collected information on middle-aged men who died by suicide, mainly information from coroner inquests and other official reports, looking at antecedents, the reasons that added up to, in the end, to a suicide death. It's a large study, and it's, I'm not going to present all the results today, of course, but I just want to make reference to one of the main findings, which is the cumulative risk that many men face. And so if we're talking about preventing suicide in men, and particularly middle-aged men, then we need to recognize all the factors that come together to put them at risk. They start early, parental separations and mental disorder, but then during life, a number of risk factors begin to accumulate. Financial stresses like debt, alcohol, physical ill health. We found that physical ill health, even though these weren't elderly men, these were men in middle age in their 40s and 50s, but physical ill health was quite common. And then quite often there's a stressful final event, a final straw event, which acts on top of these accumulating risks and tips the person over into self-destruction. Now, each of these phases has its own prevention. So to prevent suicide in middle-aged men, if they are the people we will worry about in the future, then we need to be thinking about economic protections. We need to be thinking about how we support people with substance misuse, how we address physical comorbidity in people with mental ill health. We need to be aware of financial stresses, but also other kinds of stresses in young people, in middle-aged male lives, relationships, workplace, contact with the criminal justice system. It is a broad task. And one result in our study was particularly important. It's generally believed that men do not seek help when they are in crisis. We found that that was a simplistic view, that actually the majority of men had sought help at some point. And in 2/3 of cases, that had been in the previous 3 months. So recent help, in particular from the NHS, including mental health services, but also other parts of the frontline services, the justice system, and so on. So an important message, men often do seek help, but they may not seek it in a way that leads to a response from frontline agencies. And we need to be better at working on that. We need to work better together, and we need to work with the third sector, who often provide a setting for men that they find more acceptable, and a place where they can be more honest about the problems they're facing. So men are one group, and then there's young people. Young people, mentioned the concern about them, which turned out not to be the case in the early pandemic, but since then, concerns about young people and their suicidal behavior and where that might take us in the future have grown. So this is a very interesting slide from colleagues of ours in NHS benchmarking, who collect NHS data independently, based in Manchester. And they are showing referrals to CAMS services, so children and adolescent services, during the course of recent years, last 10 years or so. And as you can see, there's been a rise in how often people are referred to CAMS in recent years. And then it's a clever slide because once we get into the pandemic months, the slide goes from annual to monthly, and you can see there's the same drop that I showed you in self-harm figures earlier. But since then, a steady rise, so referrals increasing to CAMHS more and more. So as a reflection of the mental health problems that young people were facing, a sign that more and more were seeking help during the course of the pandemic. There's a drop, incidentally, in the second wave, and you might say slightly lower figures in the most recent months, but overall a message of rising demand for CAMHS services as a reflection of morbidity. And here from the same Manchester data source I showed you earlier, young people attending hospital because of self-harm. So again, here is the pattern in the early pandemic, dropping during in the early months, and then that same rise, and into the second part of the second wave, a small drop round about here, but recently relatively high figures, again higher than we were seeing pre-pandemic. So again, a second sign that this period has been different. The later part of the pandemic for young people may not have offered the protection of the early period. Now, what can we be doing about young people's suicide risk? So again, let me draw on one of the inquiry studies, again, a national study collecting data from coroner records pre-pandemic, telling us about the pre-pandemic problem, which we are still dealing with. A national study of 600 suicides in people under the age of 20. Just pause on that figure for a second. A 3-year sample, 200 deaths a year among teenagers. The majority 40% had no service contact with any kind of child protective service. And in the majority, there had been no recent service contact. So out of touch in many cases with people who might have helped them. And what the graph is showing is the rising risk in young people during the teenage years. Something happens in the lives of young people to go from a very low suicide rate to a more or less adult suicide rate over about 5 years. Now, what did we find was happening in those young people's lives? Well, a lot of themes, but some important ones to highlight. Self-harm, of course, was common. It's worth saying that the new NICE guidance on self-harm, in which my colleague Nav Kapoor is a key advisor, published today. So self-harm services, probably the most important ones to get right for young people. Academic pressures on young people. Bereavement, surprisingly common, including suicide bereavement. The use of the internet, but not just on social media, often searching the internet for suicide methods that might be used. It's amazing what a free-for-all the internet can be for dangerous information. And bullying, particularly in young LGBT individuals. So some very important pointers towards the breadth of suicide prevention in young people. So we've got middle-aged men to focus on, we have young people, and then thirdly, we have people who are under mental health care. Now, in the confidential inquiry, we've collected as much data as we can on suicides, real-time deaths of people who are currently patients. And we've got a data collection. This is soon to be published in our annual report, over 300 deaths over a period of time. Now, that's far fewer than the total number that might have taken place, so we have to be cautious about the numbers. But nevertheless, they're telling us about key features of some deaths of mental health patients. Often in community settings, we've been worried about acute care, but in fact, the majority of deaths happen in community settings. A large number had COVID-related stresses, so that was filtering through into the lives of people who are patients. Anxiety, isolation, loss of job and financial problems. And about a third had experienced some kind of disruption to their care. So there are the indications for prevention, COVID-related factors, maintaining support for people who are vulnerable. Okay, but what else are we heading towards as we move into the next phase of the pandemic? So the final part of my talk, I just want to mention some of the features that are on that earlier slide about where we might be, where we might need to reshape our suicide prevention priorities. So I mentioned long COVID. We know that chronic physical disability is linked to suicide risk. What do we know about long COVID? So this is a slide taken from data collected by the Department of Health and Social Care it is now, and slightly squash slide, but so two graphs. The top one is showing the impact on people's lives. So this is persistence of symptoms after COVID infection. The top bar in each, these are different age groups on the bottom. Now each age group is showing, this is people who have got persistent difficulties after recovery from COVID. And as you can see, that's the orange section of each bar. And as you can see, that as you get into the older groups, there's a higher number of people and a higher proportion of people who are reporting persistent physical symptoms. So if we're linking risk to that persistence of physical disability, the greater risks are in the older population. What else do we know about long COVID? Well, here are the rates that are, it depends a little bit on how you define it, but if we take a fairly broad definition of long COVID, here are the rates according to where people live and the social characteristics. So the highest rates in deprived parts of the country. So again, this coalescence of related risk factors, age, isolation, disability, economic stress, adding up to the future COVID-related suicide prevention challenge. Now, what about social cohesion? Well, I mentioned social cohesion. It's an important concept in suicide prevention, and it gives me an opportunity to put up a picture of Emil Durkheim, one of the great, of course, suicide research pioneers in the 19th century. Durkheim wrote a lot about the potential protective effect of social cohesion. This is Durkheim's grave in the Montparnasse Cemetery in Paris. Now, so social cohesion, but how do we measure social cohesion? Well, one way is to take a marker, which in itself is quite narrow, but maybe an indication of something broader. And that's what the Office for National Statistics do. They publish this as government data, and it's recording in the early pandemic how people felt that they were, how much they felt they were in contact with their neighbors. So taking that as a marker of society working together. The red and yellow these are different groups. The red and yellow is people who felt it got worse, and the green is people who felt it got better. And what we're looking for here is a larger number of people feeling that their contact with neighbors got worse than thought it got better. So because that's an overall deterioration. Who thought that? Well, it was young people and it was ethnic minorities. So there's an indication of where social cohesion may most have broken down. The peer group support of young people and the community support for ethnic groups. Now, what about Omicron? So now we come into a new wave of the pandemic, some not much data because it's relatively new, but here's what we know from ONS. So ONS throughout the pandemic have been asking people how worried they were about the effect of the pandemic on their lives. And you can see what I'm getting at here. The more worry we feel, the more there will be some people for whom that worry is so severe that they may be at risk. So here's what happened. So reflecting the earlier slides I showed in this talk, a lot of people feeling anxious and worried in the early pandemic. This takes us into the beginning of the second year. This is about 9 months in. People still reporting that they felt very or somewhat worried during that second wave. But then during the course of last year, 2021, people beginning to feel less concerned, more positive, until we reach November, December, and then into the beginning of this year. So it's the very, very recent data. The Omicron was identified as a variant of concern at the end of November. So a rise in people feeling that they're worried about the effect of COVID. So a downturn in their emotional improvement. And finally, there's the issue of emotional exhaustion. Very interesting slide from ONS. ONS have been, throughout the pandemic, have been asking people how long they thought it would take before life got back to normal. And I've just selected some of their data for the purpose of this slide. But right at the beginning of the pandemic in 2020, the majority of people thought that it was going to be short-lived, and maybe that was protective. As the pandemic went on, even though time was passing, people could see it projecting further and further into the future. until we reached the later part of last year, when the commonest answer was that it still would be another year before life would get back to normal. So a sense of weariness creeping into how people responded. And now, so says December, it was actually December, beginning of January. So the most recent figures suggesting it's similar figures for the more than a year answer, but fewer people now saying that they think the pandemic will be over within a few months, and a rise in the number of people, this purple bar, the rise in the number of people saying that life will never get back to normal. 13% of us, one in 8 of us saying that it will never get back to normal. And if that emotional exhaustion takes hold, then that in itself may be a breakdown of what has protected us. So much to be concerned about, even though the results have so far been reassuring. There is no doubt the pandemic has had an effect on our mental health, but this has not translated into a rise in suicide or self-harm. It's an evolving pandemic. The future risks lie in economic adversity, isolation, long COVID. We should be concerned about young people. I've mentioned middle-aged men too today, and mental health patients. And many of these factors come together in the same people. Our prevention strategies are therefore about the need to strengthen economic protections long-term, mental health care as well. I didn't talk much about media coverage except at the beginning, but that's important too. And so also our attitudes to the pandemic itself, but also to each other. And a reminder of the point I started with. Getting through this, recovery from the pandemic in mental health terms, is partly about the impact of the infection itself, but it is also about what was wrong in society before the pandemic ever hit. Thanks very much for listening. And finally, a photograph of the people who did most of the work in this talk, the confidential inquiry team.
Thank you, Lewis. Thank you. That's an excellent talk. Can we give you a metaphorical round of applause? It's always quite tricky to do this bit on Zoom, but thank you. That's an excellent talk. And I think the final point was really poignant as well and sums up the presentation. The chat's been very active. So I guess we're going to take questions from the chat that's already there. But if people want to continue adding to the chat, we can see how many questions we can get through in the last 10 minutes. I noticed that Ariana unfortunately put a point about her loss on there, or her unfortunate loss, which triggered lots of conversation about the importance of perceived loneliness as opposed to actual loneliness in people. I don't think there's a specific question from that though, although people were echoing the importance of that point. So the first question that I came across that hadn't been answered was from Ranjana, which said, do you think that working from home during the pandemic has made people feel more lonely, or has it helped people to feel more safe and less stressed? I guess it's a topic of debate, that one, isn't it? But I don't know if you wanted to say anything to that, Lewis.
Well, it's an interesting question. I don't actually think we know the answer, but it is also a possible reason why for some people the pandemic was more stressful and for others less so. So I think one of the, in a way we started with the question, what's going to be the effect of the pandemic? That's what the question that was on everybody's mind. But in fact, in the end, it is a number of questions masquerading as one, because the effects are probably multiple. They depend on, it's for different people, different parts of the country, different kinds of personal situations. People have been affected differently and probably at different times. I think the evidence, and certainly the anecdotal reports, are that for some people, being out of the workplace was protective, that some people felt better. They may have been less in contact with people, but for some people, the workplace is not a pleasant place. And being removed from some of its pressures was probably protective for some people. And in which case, the return to the workplace that we're expecting will happen over the course of this year does carry some risks for us. But of course, for some, it will have exacerbated the sense of isolation. And for those people, the return will be quite important and therapeutic.
Okay, thank you. This is a question from Sandra. The long-term impact of the pandemic is yet to be known. What can be done to prioritise suicide interventions in the case of a future pandemic? God forbid.
A future pandemic. Well, I think it's making an important point about the way that the pandemic will evolve. So even if we don't have another pandemic around the corner, this pandemic will run in different ways for some time yet. possibly with further waves of infection, but even without that, there will be longer term economic consequences. There will be young people who will experience the effects of their disrupted education and employment opportunities coming out of school and university. There will be other people who have lost the chance to get the physical treatment that they needed because the NHS was under such pressure. They will be affected long term. And I've repeatedly stressed the problem of the economy, which is always long term. It starts with a threat to people's jobs, but over time, if you look at what happened in 2008, it starts to change. It becomes people getting into debt. It becomes people who are facing housing instability. It becomes people who are starting to gamble and lose money that way. So the economic impact longer term is a key part of how we need to plan prevention.
Sure, and gambling was mentioned as a key factor in the chat as well. Vicky's asking about domestic abuse and parental conflict and whether that was included in any of the categories for antecedents to young people's suicide and self-harm.
Yes, it was. So that's been an important issue in the pandemic. Obviously, people essentially enclosed with each other, and where relations were already troubled, there have been risks. You probably know that calls to domestic violence hotlines increased quite markedly during the early pandemic, so much so that there was quite a big amount of funding went into supporting those helplines. So there's no question there's a risk there. In our study of young people, being exposed to parental domestic violence was quite a common antecedent.
Okay. And H. Peters says, I'm surprised that trauma was not listed. I'm assuming that's referring to those same antecedents as well. And I'm assuming by that history of trauma.
Well, that's quite a general thing. There's quite a lot of trauma on that slide. People have, there are a number of childhood antecedents of poor mental health and quite commonly found in suicidal groups. Child abuse and neglect were common, parental mental illness and substance misuse, and as I've said, domestic violence, all part of the overall picture. These are often early experiences, and the ones that are more open to current prevention are the more immediate ones, the more recent, more current stresses that people face, and there are plenty of them. I mentioned self-harm, I mentioned substance misuse, online safety, bereavement, bullying, and so on. There's plenty of prevention opportunities.
Okay. And Catherine's put a comment about only seeing binary figures and male, female, as opposed to trans and non-binary, and the fact that trans and non-binary communities might have significant risk factors as well. Although somebody's pointed out later, it's probably because that data is coming from the coroner, which is still quite binary. I don't want to say anything about that, Lewis.
Yeah, we in national statistics, at the moment, the figures we get are for males. That's just how national statistics are recorded through inquests. In our study of young people that I referred to, we did record people who LGBT groups. So there was we did our best, bearing in mind that we were using inquest reports to record when the person had been known to be from an LGBT group. And it was a significant minority of the overall picture. And very importantly, it was a group who seemed to have higher rates of some kinds of antecedents, and that included using the internet in ways which were distressing, so online bullying, and in general, their experience of bullying and intimidation from other people, that was a more common antecedent. Now, you could say, therefore, we need to be protecting people, LGBT individuals, better. I think that's true, but it is also a pointer to a social problem. When you've got a problem of intimidation in society, then we should start with the intimidator and realize that the way people behave has mental health consequences.
And just in time for a couple of questions. There's one here from Ange, asking if there are other groups that we need extra vigilance in relation to as we recover from the pandemic, such as new mothers and people in the perinatal period.
they don't feature. I mean, it's an important group because not all that many people die in the perinatal period, but one of the main reasons they die is suicide. So in general, pre-COVID, it's a good illustration actually, the point I made at the start, which is that was an important pre-COVID problem. And COVID may or may not have made any difference to it, but it was an important pre-COVID problem. So it is part of how we recover. I mean, for many pregnant women, the fears around COVID are bound to have created distress and uncertainty about the likely impact, about the potential for impact on the child and so on. So I think we have to be pretty vigilant about a group whose pre-existing risk may have been exacerbated, but I don't think we have any figures at the moment on how that might be.
Okay, and then probably just one final question that picks up on two questions actually, because we've got two very related questions. That asks if the data's been broken down in terms of people's professions or employment groups. So certain job roles affected more during the pandemic than others.
We haven't done that yet. So here's another good illustration of how we need to bring our pre-COVID knowledge to bear on the post-COVID problem. We know that people in certain occupations are at higher risk, and they tend to be low pay, low skill occupations. And so we need to just be aware of when we're talking about the economic impact. And I made a point about men and the fact that economic factors seem to be a very powerful driver of suicide rates in men, particularly middle-aged men. That's undoubtedly true, but it's not just men. I don't want to give the impression just men. And we can expect that there will be an equivalent effect on other low pay groups. And I'm sorry to say that is very often about women in low pay jobs. So we can't be in any way assured that the economic risks are confined to men. They're likely to affect low pay jobs, which often are women predominantly. And we've seen this in some countries. One of the explanations for the rise in female suicide, specifically in Japan, is that women are often in low paid jobs in Japan more than in many other parts of the world. So occupational risk, we don't know much about it during the pandemic itself, but applying what we already knew, we need to be concerned about low pay occupations. Okay,
thank you. And Alice just posted a paper about nurses on there as well. Okay, I think we're going to have to finish there. And there's lots of thank yous and positive comments about your talk, Lewis, in the chat as well. So hopefully you've had opportunities just to read through those. But once again, thank you very much for your time today. It's been a pleasure.